All right, I'll just go ahead and start. So we will start with POCSO. Okay, Protection of Children from Sexual Offences Act, POCSO. All right. Possible questions in this are child sexual abuse can be asked, POCSO per se can be asked, or role of a pediatrician in a case who's coming with sexual abuse. So these are the ways in which the questions can be modified. Okay. So we will see what is in the article, then I'll give you the extra points. So what is child sexual abuse? Sexual abuse is any form of victimization, sexual victimization of children. What do you mean by sexual victimization? It can be an actual act of sexual intercourse. It can be penetrative or non-penetrative, or a sexual harassment, or commercial use of children for pornography, or showing them pornography. Any form of this is called as a sexual victimization, a child sexual abuse. So in order to protect the children came the POCSO Act. POCSO, P-O-C-S-O. POCSO is Protection of Child from Sexual Offences Act. Okay, so that is POCSO. It came in 2012. So what was the need for this POCSO? Write down these points. These points are not there. Okay, the reason why the POCSO came into act was the Indian Penal Code that is usually there in existence does not provide action against all sorts of sexual offenses. There's no difference between adult versus a child victim of a sexual offense. There is no protection for male victims. Male children are generally not considered as victims of a sexual offense. And unnatural offenses were not covered in our Indian Penal Code. These are some of the reasons for bringing out this POCSO. So what are the reasons? I'll repeat again. It does not protect or provide against all sorts of sexual offenses, especially unnatural offenses are undefined. So those do not come under the Indian Penal Code at all, and they may not get punished at all. And there's no difference between an adult victim versus a child victim. A child victimization is very, very bad compared to an adult victimization. And there was no protection for male children. Hence, the need for this POCSO. This POCSO came in 2012. Okay, so before that, it was only IPC. After 2012 came POCSO, and 2018 there was an amendment, and 2019 there was an ordinance. So we will discuss about that later. So this is the introduction for your sexual abuse. So what is sexual abuse and why did POCSO come into play? So if a child is coming to you with history of sexual abuse, what are you supposed to do? So every case of sexual assault should be considered as a medical emergency, and they should be treated irrespective of whether they have gone to give a police complaint or not. Okay, it does not matter. It does not matter whether they go to a government or a private medical facility. Every child should be treated free of cost. Okay, and it should be emergency attending. Suppose they come with a police complaint or a court order, then you can go ahead and examine the child. If they are coming to the doctor directly, if they are coming to the pediatrician directly, then medical examination can be done after consent. The child may refuse medical examination, and that is still okay. Medical examination is not mandatory. What is mandatory is reporting. Okay, not reporting a sexual offense of a child is considered for punishment of up to 6 months and or fine. Okay, so this is one of the mandates of POCSO. All right, so the child may come to you with history. Child and parent may come to you with history, but they may refuse examination. That is still okay. Okay, you can document that the patient has refused medical examination, but what is not acceptable is refusing to report to the police. So reporting is very, very important. So remember that point. If they do not want examination, you will document that. If they do not want to make a case, then also you will have to document. You will put a MLC, okay, and you will get a sign for refusal to register a case. So this is important because in future, if they want to go ahead and register a case, you will still have records. All right. Then medical evaluation of a child who is subjected to a sexual abuse. So what are the things? 4 things. HEIT, correct? History, examination, investigation, and treatment. So first you need to see the age of the child. So in order to ask history and examination, if the age of the child is less than 12 years, the parent or the guardian are the ones who are going to give you consent, history, etc. If the child is more than 12 years, consent of the child is very, very important for medical examination. Okay, less than 12 years, it is parents or guardians. More than 12 years, it's going to be the child who is going to give you the consent. Next, in history. History should be a facilitative, non-judgmental. All right, you're not going to judge the child. You're not going to say, oh, this happened. No sorts of emotions are going to be given to the child. All right, so it should be a very, it should be asked in a very empathetic manner. It should be asked in a very non-judgmental manner. All right, you're not going to say it is too bad or too good. Nothing should be told, and you should ask in a very, very calm way, composed way, without showing much emotions. All right. And during history, the other things that you're supposed to note are the family's background. How was the child brought up? Where is the child going to go? The child's mannerism while the child is giving you history. Whether there are indicators in the demeanor that will suggest that there has been an abuse. I'm sorry, there has been a power cut, I think. All right, so let's just continue. I think I'll still have the internet connection. So this information will help you understand the child's background. All right. The names of the child that the child uses for representing body parts is important to note. So it can be different in different cultures. They may use the actual anatomical names. It's very, very rare. But what they use in house should be documented. And the child's behaviors during representing those names is very important. So these are the things in your medical history. The family's background, the developmental level of the child, what the child uses to represent names, and in child's own words, the history should be recorded. Okay. And if there is any past medical history that is suggestive of abuse, that is also supposed to be noted. And in history, when all of this is complete, last you will specifically ask for any injuries, bleeding or discharge at the perianal region, periurethral region, perivaginal region, depending upon the sex of the child. So this is your history. What about your examination? See, doctors are legally bound to examine and provide treatment to survivors of sexual violence. It's important to report, document, and collect evidence. All right. So police personnel should never be present when you're doing an examination. Who should be present is the mother or a guardian that the child trusts. Preferably, a female child should be examined by a female physician or a female pediatrician. Suppose the mother or guardian could not be there, or there is nobody for the child, then a person will be allocated by the head of the department. So that person will come there and be there during the examination. So the elements of physical examination are: the child should be calm, child should be in an appropriate position for examination, which is the frog leg posture or a knee chest or a left lateral decubitus. First, your regular inspection will be done. Okay. See what is happening in the anogenital area. You look for signs of infection, injury. Next, examination of the external structures, mons pubis, labia majora and minora. Then examination of internal structures. Internal structures you will do by means of using a colposcopy or a speculum. Then, if required, specimens will be collected. Ideally, the specimen collection from the site and from the dress or skin will be collected if the abuse has happened within 96 hours. Beyond 96 hours, then it's less likely that the child is going to come out with any of these specimens coming to be positive. Okay. So this is about examination. Examination may reveal positive or negative findings. Negative findings are more common, in fact. Why negative findings are more common? Because usually they present late, and usually the victims are assaulted by people who are actually in charge or people who are close to them. So they generally do not leave any external injuries. There are no external markers to suggest that this child would have had a penetrative assault, because sometimes it may be a non-penetrative sexual assault. And mucosal tissue in children can be very elastic, resulting in just distension and not tearing and injury. So these are the points in your examination. What about investigations? Investigations you are going to do mainly to collect specimen. Yes, one. Next, to see if the child has contracted any infection. It can be a bacterial infection, or it can be a sexually transmitted infection like gonorrhea, chlamydia, syphilis, trichomonas. You will look for herpes virus. Then you will definitely do a serology for HIV. Then your forensic evidence to find the perpetrator. These are investigations. Forensic examination, as I said, within 96 hours of sexual contact, you should be able to collect. You will be able to know whether the sexual act has been attempted and completed, or attempted and not completed, if there is any injury, and age of the attack, since how long before the child would have had this attack. Treatment wise, you will treat sexually transmitted diseases. If the child is post menarchal, then there's a risk of pregnancy, then you will give oral contraceptives to the child for emergency contraception. Emotional support, not just to the child but also to the family. You should document properly, report to the respective authorities, and refer them to a mental health specialist to help them overcome this acute stress period. So these are all the HEIT, history, examination, investigation, and treatment point of view to a child who is going to come to you with sexual abuse. So this is the answer you will write if the question is a pediatrician's role in child sexual abuse, or a child coming to you with sexual abuse, and what are the next steps that you're going to do. Okay. If something on POCSO is asked, so POCSO, you will write what is POCSO. Then you will write the important points. Okay, so POCSO Act was started in 2012. The reason being IPC did not cover everything. It has got 9 chapters and 47 sections. Covering everything in your answer is very difficult. Okay, so what you will write is only the important points. The points that we discuss now should also come in POCSO. Apart from that, let me take it. Yes. So the important salient features of POCSO are these. A special court is there for taking care of child sexual abuse cases. Ideally, they should dispose of the case between 6 months to 1 year and not beyond that. Next, second salient feature is mandatory reporting. If mandatory reporting is not done, then 6 months to 1 year, there can be imprisonment with or without fine. If a false report is filed, then also it will be amenable to punishment, but of lesser severe degree. Third is special procedure. What is special procedure? Special procedure is recording of the complaint, statement will be taken from the child, and evidence will be collected. So these statement collection, your complaint recording, all will be done by a female police officer. Female police officer who is not less than a SI rank. They should not be in police official uniform. They should go to the house and take, not in the police station. Okay, preferably in the presence of parents. In child's own words, it will be recorded. Again, it will be taken in a very non-judgmental manner. These are the important points on how to record the complaint. And there is a provision for compensation. Compensation will be taken from the accused. Okay, so the accused, after going to court, they will tell this much amount of fine, that is equal to the medical compensation that is required for the victim, the mental stress that they have undergone. So a suitable compensation will be decided by the court, and the accused will give to the victim. This report to special juvenile police unit. The reporting should be done to a special unit, which is a juvenile police unit that is there in every district, or you can do it to the local police station, or if these two are not possible, you can contact the child helpline, which is 1098. Easy to remember, no? 10, 9 and 8. So 1098 reporting is not considered as reporting. It is just facilitating of the reporting. So they will help the doctor get in touch with the police people. So these are the salient features of POCSO. What are the punishment for offenses? Punishment depends upon the severity of assault. Okay, so it can be a penetrative sex, which is explanative in itself. Then it can be aggravated assault. What do you mean by aggravated? Okay, so the term aggravated means it's usually done by a person who's in a position of trust. Okay, so if the assault is done on a mentally ill child, if the assault is done by a person who's in trust position, it can be a teacher, it can be a parent, it can be a relative, it can be a police officer, army officer, doctors. So they are all in a position of trust. So if they do a sexual assault, then it is called as an aggravated sexual assault. If the child is less than 12 years, if some deadly weapons were used, or if more than one person was involved, all of these constitute aggravated sexual assault, and the punishment is more severe. Say for if just a penetrative sexual assault is 7 years with or without fine as the minimum punishment. Aggravated assault will have 10 years. Okay. So these are the common punishments for different offenses. The intent to commit is also considered as an offense, even though if it is not complete. The punishment duration will be half that of what would have happened if the act was completed. And punishment is also there for abatement. If somebody aids, then that is also considered as a sexual offense, and it will be how to tell, it will be treated as an offense and it will be punished. The amendments that came in 2018. So 2012 to 2018, there was no change. These were the salient features. But what did not do well was less than 16 years, less than 18 years, everybody were considered same. So here they changed. If somebody is assaulting a child who's less than 16 years, then rigorous punishment of 20 years, which can be extended to life. Okay, life meaning if adult somebody's how to tell, put in jail telling there's a life imprisonment, it can be 20 years or 25 years. But here life means actually life. Throughout their life they'll be in jail. Okay, so less than 16 years till 20 years or extend to life. If the child is less than 12 years, then imprisonment for same 20 years life. There can also be a death penalty. Okay, so this is amended in 2018. What is the ordinance that was passed in 2019? The ordinance that was passed stated that there is no anticipatory bail. Okay, anticipatory bail cannot be done. POCSO cases should be disposed within 6 months, and a fine should be given to the victim that is equal to the medical expense and rehabilitation that is required for the victim to undergo. Okay, so this is about the amendment and ordinance. Special Juvenile Police Unit we discussed. The reporting should be done to the Special Juvenile Police Unit, and they will report to the Child Welfare Committee within 24 hours. It's a child-friendly procedure. It will be done in the residence. It will be done by a female police officer, minimum SI rank. They will not be detained in the police station. They will not be in uniform, and it will be recorded verbatim as the child says. Okay, so these are all about POCSO Act. So I think if any question is asked in any manner, you can answer. Prevention, I think you can directly go through. There's nothing much about prevention. It's all like common sense. You can think and write. Okay, so that's about sexual abuse. So next, let's go on to end of life care consensus. So end of life care consensus. So let's see. So here question can be modified as end of life care, DNR, or they can give a case scenario saying this person is not expected to live for next 6 months or 3 months, and the parents or the relatives do not want to continue the life support. What is your take on this, or how are you going to proceed? So this is one type of way in which they can ask the question. So if a theory question is asked, first you need to know the definitions. Euthanasia, end of life care, resuscitation, do not resuscitate order. Okay, so these are the 4 things that you need to know. Euthanasia is what? Literally it means good death. Eu is good, thanasia, thanatos is death. Okay, euthanasia. It refers to acceleration of death by an active intervention. Why is it done? To alleviate the suffering of the patient. Why? Because the patient is in an irretrievable situation. The situation cannot be ameliorated by any means, any by medical means or surgery or supportive care. Okay, so euthanasia is voluntary, and any intervention against the patient's will is considered as murder. All right. So euthanasia is of 2 types. It's either active or passive. Active is you intervene to accelerate the death. So that is active intervention. Passive is you withhold life-saving measures. Okay, so that is passive. All right, so this is euthanasia. End of life care is similar to the euthanasia, but the only thing is you will care for the patient till their death, and after death, whatever their wishes, it will be fulfilled. So that is end of life care. Okay, does not mean you're accelerating death or you're facilitating death. No, end of life care is refers to however the person wants himself or herself to be cared till the end of their life and after their life. Resuscitation. Resuscitation is the process of restoring cardiopulmonary circulation. Okay, so as simple as that. Do not resuscitate is, this is a treatment decision that is taken by the patient or the caregiver prior to a cardiorespiratory arrest. Okay, so it is as simple as that. So this will not, a do not resuscitate order does not mean that you stop continuing care. Say suppose a child is on ventilator care, child is receiving IV fluids, child is receiving IV nutrition and vasopressors. Okay. And the parents tell, do not resuscitate. This child has already had 2 to 3 cardiac episodes of arrest. So that means if the child has another arrest, you are not going to go and do a cardiopulmonary resuscitation. But that does not mean you are going to hook the child off ventilator, hook the child off IV fluids. So that is not a do not resuscitate order. Do not resuscitate is no active intervention in case of a cardiac arrest. Otherwise, your continuing life care will go on. So skip to why do we need this end of life decisions? Okay. So there are many situations where the patients with irreversible disease or end stage disease, they continue to remain on ventilation. Okay, it's difficult for the not just the patient, it's the patient's family, doctors, nurses, the healthcare system as a whole. So what are the conflicts that we are dealing with when we are dealing with the end of life care decision? See, you are continuing a prolonged vegetative state, which is difficult for the patient and family. And for the patient, it lowers the dignity of death. It takes away their personal decision, okay, their autonomy in deciding when, how they want to die. There may not be a chance of improvement, but you're just utilizing resources which may be used for somebody else who may, who has a better chance at salvageability. And it's a significant burden for the family, both financially and mentally, to deal with somebody who's continuing to be in a vegetative state. So these are all the reasons why we need a set of decision-making policies to decide when to initiate this end-of-life care policies. So that's why the process came into being. So skip the process of forming guidelines and come to end-of-life care in page 3. So end-of-life care is defined by the National Council for Palliative Care, UK, as helps all those with advanced, progressive and incurable illness to live as well as possible until they die. Okay, so as much as possible, you keep the patient comfortable till they die. That's all, the simplest thing. It enables the supportive and palliative care needs of both patient and family. It will help in management of pain, provision of psychological, social, spiritual, and practical support to the patient and family members. So this is what it means to end of life care. The ethical principles that are involved are 4: autonomy, beneficence, non-maleficence, and distributive justice. What do you mean by each of these terms? Autonomy is the patient's right to decide when and how and where they want to die. So that is autonomy. Beneficence is acting in what is judged to be in patient's best interest. So as physicians, we are expected to act in patient's best interests, isn't it so? So you need to give compassionate care during the dying process. You keep the child as comfortable as possible. You neither hasten nor delay, but facilitate. So that is beneficence. Non-maleficence is do no harm. Do no extra, unnecessary, unacceptable procedures which may be a burden to the child. Distributive justice is treating patients truthfully and fairly. Good use of whatever is available to you to provide the best care possible. So that is distributive justice. What are the dilemmas in case of a end of life decision? It can be a legal dilemma or it can be an ethical dilemma. 2 things. Legal dilemma is when to initiate this discussion of end of life care. So we do not know. There can be questions like, should we initiate now? Can we wait? Can we wait and see for 2 days? So these are all legal dilemmas. If you initiate early also, you might be in trouble. If you initiate late also, you might be in trouble. So the end of life or end of life care, approaching end of life can be defined as a person who's likely to die in a period of 1 year from now. So they are considered as approaching end of life. Okay. Ethical dilemma is where there is difference of opinion. So the child's parents, one parent might be of yes opinion and the other parent might be of no opinion. Or it can be a sibling who is having a different opinion. Or the patient themselves might have a different opinion compared to others. So these are all ethical dilemmas where you need to bring everybody in the same page. Only then you can initiate end of life protocol. Otherwise you cannot. Okay. So this is about end of life care. What about do not resuscitate? Okay, so this till now we did not talk about anything active that you're going to do the child if the child has a cardiac arrest, isn't it so? So you were just discussing how we are going to facilitate the child child stay till the child passes away. So that is your end of life care. Do not resuscitate is, as we discussed, does not involve withdrawing of life support, does not involve stopping ongoing care, does not involve discontinuing routine care like your oxygen, nutrition, fluids, vasopressors, etc. Okay, all it means is no active intervention in case of a cardiorespiratory arrest. All right. So in India, till now, we do not have any guidelines per se for DNR. There are two terms in relation to DNR that we need to know. One is withholding life-sustaining treatment. The other one is withdrawing life-sustaining treatment. It looks very similar. Actually, they are very different. Withholding life-saving treatment is you stopping initiating a ventilation, stopping putting a central line, stopping giving a renal replacement therapy to a patient who is not salvageable. Okay, to a patient who will not recover. So that is withholding. You are not initiating anything. Okay, but this should be done only after consent. This is another important point. Okay, so prior to initiation, you will take a consent. And when you are taking a consent, you are going to tell the pros and cons and possibility of recovery of the child. So if then the parents or the guardians do not wish to continue with this life-saving method, then that is a withholding life-sustaining treatment measure. But if they insist to continue, yes, you will still continue after explaining the pros and cons of it. Withdrawing life-sustaining therapy. So this is more difficult and this should be done only after repeated and consistent discussion with parents and guardians. Okay, it should not be done without discussion. Everybody should be on the same page. Everybody should concur with your decision before proceeding with withdrawing of life support. Discussion should ideally involve a senior member who is used in discussing these sort of things. If the family members want somebody from their community to be there, yes, they should be there. If they want somebody from their family to be there, yes, they should be there. Because in India, the decision makers generally need not be the parents per se. It's usually the relatives or some known person in their community. Okay, so if they want those persons to be involved in the decision making process, yes, they should be included in the decision making process. All right. And withdrawal should never be done just to facilitate use of the equipment for another patient. That's also wrong. All right. Just because somebody needs it, you cannot withdraw this patient from life support and use it for another patient. So who are the candidates with whose parents or guardians you can discuss about the possibility of initiating a DNR? Where the box 2 is what we are going to discuss now. Where the life-sustaining treatment is ineffective or futile, it's not going to help. The patient has had prolonged unconsciousness and patient is unlikely to recover. Then yes. Terminal condition for which there is no definitive therapy. Patient has a chronic debilitating disorder where resuscitation burden far outweighs the risk of benefits. Where medical treatment is not useful at all. Or the factor may be unique to the patient, where the patient has made an already informed will and refuses a CPR. Okay, so these are all advanced directive. So what this means is advanced directive. Even before they go into such a situation, they will make an advanced will stating that I do not need any active intervention in case I go to a stage where I may not recover. So the patient will make that decision. So these are all the candidates who are who can be expected to, I can't say expected, who can be considered for DNR and can be discussed with the parents. Who are not candidates for DNR, you should not be activated for patients who are unable to pay. The outcome is doubtful. You do not know if the patient is going to recover or not, then don't initiate DNR. Always give the benefit of doubt. Always work on the child till whatever is possible within your means. If there's a conflicting opinion among family members, do not initiate DNR. If responsible next of kin is not available for the decision, then also you cannot initiate a DNR. And if written consent, they are refusing to sign a consent form, then do not initiate DNR. Because everything is medico-legal, everything needs to be documented. Without a documentation, do not proceed to the next step, especially in sensitive matters like these. Okay. So DNR issues in neonate is another ball game altogether, because neonatal decisions has to be taken by the parents. It has to be taken in the background of what sort of setup the child is in. Okay, so here very simply put, at the time of birth, you will decide or you will think about a DNR if the child is having congenital anomalies that are incompatible with life, or maybe compatible with life, but the child will have a very, very poor quality of life. Okay, then it can be considered. If the patient has already received a prenatal diagnosis, then you can discuss with parents as to what could be done when the child is born. And after the child is born, also the treatment decision might vary, and that also has to be discussed. So in case, see, you saw something in the prenatal ultrasound that was suggestive that the child will not recover at all, child has a poor prognosis, but after birth you deem the child to be having a survival chance, then give the chance to the child. Okay, so this also has to be discussed with the parents, and you should take a signature. So it varies from time to time. Even a DNR or end of life care decision has been signed, then there is always chance to revisit the decision. Okay, so down the line, if they want to revisit it, then sit with everybody, discuss, document what was discussed, and take signatures of the doctors, the nurses, the parents, whoever is present there. Okay, so because everybody has been involved in the decision making process. Right. Coming back to the neonatal DNR. So this is the important points. And gestational age wise, see, more than 24-week gestation are regularly surviving. If they are in a good tertiary care setup, then yes, even beyond 24 weeks, resuscitation will be initiated and the survival chance will be given to the child. So what is given in this article is, if the child is not able to reach a tertiary care facility, if the baby is in a peripheral center like SNCU, then below 28 weeks may be considered. Okay, personal opinion, not given in this. May be considered is the statement given in the article, but I feel even below 28 weeks do have a chance of survival. And decision in neonatal units, they speak about the same. Then criteria for brain death. If you want to declare a newborn brain death, then it depends on the age of the child. Clinical examination and apnea test should be conducted twice at an interval of 24 hours for neonates and 12 hours for children beyond 1 month to 18 years of age. So that is how you will say that the child is brain dead. And PaCO2 raise above the baseline up to 20 millimeter of mercury has to be documented. Then counseling, preparation, responsibility are things that we discussed in short. So the easiest way to go about counseling for your theory writing is, go to the front of the page where you have the recommendations. Very beautifully, 10 points of recommendations are given for DNR. So those are the points that we discussed that you need to write. The same points are given there. Okay. So first, the team will come in agreement whether this has to be discussed with the family. If they are in agreement, they will go to the family and discuss. And family, who all need to be there, will be there. Okay, so the parents, close family members, somebody from the community. If they want a specific doctor to be involved in the decision-making process, yes, the doctor also will be involved in the decision-making process. Everything will be discussed transparently. The pros, cons, what could happen, how long it can take. Everything will be discussed. Everything will be documented, signed, and if this decision needs to be revisited in the future, then also that will be done. Okay, so these are the DNR recommendations by Indian Academy of Pediatrics. The hierarchy of decision making is something that needs to be thought about. Okay, there's no actual description of hierarchy in as far as Indian setup is concerned. Okay, so hierarchy is only for inheritance of property, not for decisions like these. So here, if patient himself or herself can make a decision, is competent, then they will be the first person to make the decision. If not, if there is an advanced health directive, then that can be used. That is generally not there in Indian setup. If that is not there, the guardian. Okay, so the enduring guardian will take the decision. If that's also not there, then general guardian. Okay, so in India, generally enduring guardian recognition is not there. So whoever is taking care of the child will become the guardian. If it's an older child or an adult, then it is spouse. If an older person is there, then next to spouse will be child, then parent. So in that order, the hierarchy goes. Then review of DNR orders, process of consent and documentation. All of these we have discussed. I think if you write this much, this is more than enough for do not resuscitate question or end of life care question. Next, coming to Gaucher's guidelines. So we are again over time. Within 10 minutes, I'm trying to complete, but I'm not able to. All right. So Gaucher's, let's see if we can do it in 10 minutes. All right. So what do you know about Gaucher's disease? Gaucher's disease is the most common lysosomal storage disorder. It is secondary to a deficiency of acid beta glucosidase. This deficiency of acid beta glucosidase results in accumulation of glucosyl ceramide. All right. This glucose cerebroside or glucosyl ceramide accumulates in lysosome. Lysosomes of tissue macrophages especially or reticuloendothelial system. Apart from that, it also accumulates in brain. It accumulates in your hematological system, osteoblasts, immune cells, etc. Okay. So this acid beta glucosidase deficiency is due to mutation in GBA gene. Okay, GBA gene present in chromosome 1. Alright, chromosome 1q is the location of the GBA gene. So this will be your introduction. It's an autosomal recessive disease, most common lysosomal storage disorder, secondary to acid beta glucosidase deficiency, resulting in accumulation of glucosyl ceramide in your reticuloendothelial system, osteoblasts, hepatocytes, and brain. All right. So Gaucher's disease in India. Next page, if you see, it's a pan-ethnic disorder. It affects everybody. Okay, Gaucher's type 1 is more common in the Ashkenazi Jews, whereas everything else is pan-ethnic. There are 4 mutations that is common in 95% of Gaucher's patients. So please note this down. 4 mutations are N370S, L444P, 84INSG, then IVS 2+2. So these are the 4 mutations: N370S, L444P, 84INSG, and IVS 2+2. Among this, in India, L444P is the most prevalent. Okay, so most prevalent in all of the country. In northern part of the country, there are different rare private mutations that are happening, but overall, it is L444P in India. What are the types of Gaucher's disease? See, Gaucher's disease is basically classified based upon whether the child is having neurological manifestations or not, and 2, the progression of neurological disorder, whether it is acute or subacute. So 1 does not have neurological involvement. 2 has acute neurological involvement, infantile. 3 has neurological involvement, it is subacute. Okay, so 3 is divided into 3 types. So let us see what are the classical features in each. So type 1, as we discussed, it's a non-neuronopathic form. Basically, there will be a huge splenohepatomegaly, skeletal disease will be there, hematological involvement, pulmonary involvement will be there. No neurological manifestations. Type 2 is infantile form. So infantile form can present as perinatal death with non-immune hydrops. They can present after birth with stridor, okay, due to laryngospasm. Failure to thrive and stridor can be the presentation of Gaucher's type 2. All right. They have neurological features which are acutely progressing. The classical neurological feature is bulbar and oculomotor paresis. In fact, oculomotor apraxia is one of the first signs of a Gaucher's disease. Okay, in a neurological Gaucher. This is type 2. Type 3 is subacute progression of neurological involvement. So there is type 3A, 3B, and 3C. So what are the classical features? Type 3A has progressive myoclonus and dementia. Type 3B has horizontal supranuclear gaze palsy. 3C, C for cardiac and cornea. They have corneal opacities and cardiac manifestations. What are the cardiac manifestations? Aortic valvular regurgitation. Okay, so 3A, 3B, and 3C. 3A is progressive myoclonus and dementia. 3B is horizontal supranuclear gaze palsy. 3C is corneal opacities and cardiac anomalies in the form of aortic regurgitation. Okay, so these are the classifications of Gaucher's disease. So I am adding the actual Gaucher's disease also. If such a question is asked, you'll be able to write that. And if guidelines is asked, then you can just give an introduction and directly go into the guidelines. Okay, so come to recommendations in the next page. The recommendations in the next page for investigations and treatment. So investigations, 4 ways you can diagnose Gaucher's. One is enzyme diagnosis, where this enzyme is deficient. Second is molecular diagnosis, where you say this is the mutation. Third is tissue biopsy, where you find the classical Gaucher cell. The fourth one is trying to find out biomarkers. Okay, so let's see each one by one. Enzyme diagnosis is the gold standard. Which enzyme is deficient? Acid glucosidase. You will find that in blood leukocytes, the levels are less than 10%. Okay, so this is the gold standard for diagnosis. Through dried blood spots, this can be diagnosed. The only caveat here is there can be, how to tell, false results by doing this. Only in certain conditions there are false results. So in that situations, cultured skin fibroblasts can be used instead of leukocytes. Why there is false positives, or how to tell, ambiguous results where you're not able to decide whether the child actually has Gaucher's or not? The reason is the child can have associated saposin deficiency, or the child can have a GBA mutation that actually results in trafficking of the enzyme, or there can be a Niemann-Pick disease which is mimicking like a Gaucher. So these are the three possibilities where you can have an ambiguous result by a dried blood spot. So in that case, you can do a cultured skin fibroblast. So this is about enzyme diagnosis. Less than 10% activities, leukocyte, gold standard. Molecular diagnosis is you look at the genetic mutation. What gene? GBA gene, chromosome 1. What sort of mutation you will look for? What is the importance? You will actually know what is the mutation, so you can give prognostication. You can give, how to tell, if a prenatal diagnosis is required, you can specifically look for that mutation rather than going in blind. So that's the importance of molecular diagnosis. Second important point in molecular diagnosis, this is the investigation of choice for diagnosing carriers. Carrier testing cannot be done by enzyme diagnosis. Okay, so carrier testing has to be done by molecular diagnosis. Next, role of tissue biopsy. Tissue biopsy, you will do you will look at Gaucher cells. Okay, so the Gaucher cells are hallmarks of Gaucher's disease, but they are not diagnostic. Okay, so the Gaucher cells can also be seen in other conditions. They are pseudo Gaucher cells. They can be seen in thalassemia, HIV, mycobacterial infection, hematological malignancies like granulocytic leukemia and myeloma. So these are pseudo Gaucher or Gaucher-like cells. Okay, but you can do a hepatic biopsy, bone marrow examination to do, but what is recommended is do not do a hepatic biopsy. Reason is due to hematological involvement, there will be thrombocytopenia. Hence, there is an increased risk of bleeding. Plus, if there is severe hepatic involvement, then also there is a risk of bleeding. So, do not do a liver biopsy just to find Gaucher cell. It's not going to help you in any way. So, do not do that. Splenectomy again should not be done as a misdiagnosis. Okay, so splenectomy, some people do thinking that it's something else apart from Gaucher's disease. So unexplained splenomegaly, unexplained thrombocytopenia with some bone pain, that child should always undergo testing for Gaucher's disease. That is very, very important. So that's about tissue biopsy. So tissue biopsy, not useful. If it is done, Gaucher cell is what will be seen. What is Gaucher cell? Gaucher cell is a 20 to 100 micron size cell which has intracytoplasmic PAS positive inclusions. Okay, it gives a wrinkled tissue paper appearance. This is a Gaucher cell seen in Gaucher's disease. Okay, 20 to 100 micron size cell with intracytoplasmic inclusion resulting in a wrinkled tissue paper appearance. Next is biomarkers. There are three biomarkers: chitotriosidase, CCL18, and glucosyl sphingosine. Three things. Chitotriosidase is the most common that is used. This is something that is, it's a biomarker that is secreted by the Gaucher cell. Okay, it can be seen in other lysosomal disorders and thalassemia, but the difference is there is 1,000 times elevation in Gaucher's disease compared to other disease. The only caveat here is if the patient is having a polymorphism in CHIT1 gene, then the rise may not be as significant as expected in any other case of Gaucher's disease. So in that case, you can use a CCL18, but CCL18 is not available in India. Glucosyl sphingosine is a validated key marker, a biomarker for Gaucher's disease that is slowly upcoming. Okay, so these are the four methods of diagnosis: enzymatic diagnosis, molecular diagnosis, tissue diagnosis, and biomarkers of Gaucher's disease. So if diagnosis of Gaucher's disease is asked, all four things should be written. What about management? Management, again, See, investigations wise, you have already done a molecular diagnosis and your enzymatic diagnosis to find the associated features, clinical features. You will try to find out by investigation. If the child is complaining of bone pain, you will look for avascular necrosis. Marrow infiltration should not be done looking at MRI, because that is not going to differentiate a cellular marrow versus an infiltrated marrow. So that won't help you in any way. If the child is having respiratory problems, you will look for pulmonary infiltration and spinal deformities. You will look at a DEXA scan to look at osteopenia. So whatever the child is complaining of, you will do an investigation to find out the cause. Disease-specific management is enzyme replacement therapy and substrate reduction. These are the two main modalities apart from supportive care. Enzyme replacement therapy, beta glucosidase is deficient. No, so you replace that. As simple as that. So what are the medications that are used? They are, one is imiglucerase. Okay, imiglucerase is what is approved in India. Next, vilaglucerase alpha, taliglucerase alpha. Imiglucerase, vilaglucerase, taliglucerase alpha. These are the three enzyme replacement therapies that are available. Imiglucerase is approved in India. Imiglucerase therapy is given at 60 international units per kg. Every 2 weeks it is given. It has to be taken lifelong. It reverses organomegaly. It reduces skeletal involvement and reduces hematological involvement. It does not have a role in neurological involvement reversal. Neurological involvement will not reverse, so it is not advised for neurological Gaucher's disease. Okay, so neuronopathic form of Gaucher's disease does not use the replacement with your enzyme. Okay, so treatment with enzyme replacement therapy should be considered for every other form of Gaucher's, especially type 1. Okay, if avascular necrosis is there, you will definitely consider. Repeated requirement of transfusion is an indication for enzyme replacement therapy. POCSO has the initiation and the criteria for initiation of enzyme replacement therapy. If the child is having failure to thrive, splenohepatomegaly, severe hematological involvement characterized by hemoglobin less than 8, platelet less than 60,000 and leukocyte less than 3,000, symptomatic bone disease, prior splenectomy, symptomatic pulmonary involvement. These are all indications for initiating an enzyme replacement therapy. Administration, we already discussed, but the administration should always start after consent from the parents, because this is going to be a lifelong process. It's going to be a financially constraining thing for the parents. So it has to be discussed with them and then started. If there is a deficit of the enzyme replacement, you can initiate at half the dose at 30 international units and increase if the child is not having symptomatic betterment. Then recommendations for therapeutic goals, you can go through the table. It's very extensive. The first thing that will improve is patient's general well-being. That takes 6 months to 12 months or 1 year. Okay. Adverse events is as with any other medication, nausea, vomiting, diarrhea, you can write. Since this is a recombinant thing, you can also write some fever, rash, headache can be associated. Substrate reduction therapy, two medications are approved. This is oral. Enzyme replacement therapy was IV. This is oral. Miglustat and the other one is eliglustat. Okay, so these are all oral replacement therapy, oral substrate reduction therapy. Okay, so this inhibits glucosyl ceramide synthase, which is the rate limiting enzyme in the synthesis of glucosyl ceramide. If glucosyl ceramide is not formed, it is not going to accumulate at all. Isn't it so? So they are reducing the substrate by inhibiting the enzyme that is important for forming it. So this is about substrate reduction. Supportive management, if patient is having bone involvement, osteopenia, then bisphosphonate can be given. Vaccination has to be given. Nutrition has to be taken care of. If frequent transfusions are required every 2 to 3 weeks, still requiring massive loads of transfusion, then that's a very important indication for enzyme replacement therapy. Because too much blood transfusion, what happens? Glycolipids accumulate, and that is going to worsen the progression of Gaucher's disease. So it should not be done. Splenectomy, unless it's going to be life-saving, do not do a splenectomy in a Gaucher's patient. Hematopoietic stem cell transplant is not recommended treatment. So that's all about Gaucher's disease. Genetic counseling and prenatal diagnosis, just like any other genetic counseling, you can write. Prenatal diagnosis will be done with your chorionic villus sampling, amniotic fluid analysis, or your cord blood sampling. The risk has to be explained to the parents. With every pregnancy, there is a 25% chance, because this is an autosomal recessive disorder. That's it. We have completed Gaucher's disease. So thank you for listening to me. Again, we went well over time. I think we should, reduce the number of topics, because discussing 1 hour every day is difficult. All right. So tomorrow, as we decided in our group, I will be discussing two topics. One is ADEM, and the other one is approach to a floppy infant. All right. All the best. Take care. Read well. All right. We will meet again tomorrow at 6 o'clock to discuss these two topics. Bye bye.